This is the third in the series of presentations on the topic of radiography of musculoskeletal trauma and repair. In this presentation, I will describe and provide examples of fracture healing as evaluated with radiographs. And by the end of the presentation, you should be able to identify and describe the radiographic appearance of that healing and be able to determine when fractures are healed. Fractures heal by periosteal and endosteal proliferation, which is usually termed a callus. And the callus is a solid and generally smooth periosteal and endosteal reaction, which should be really centered at and localized to the fracture. However, the production of bony callus is variable and is dependent upon a lot of factors. Those factors can include location and type of fracture, the type of stabilization used, the local blood supply, the patient species and age, as well as any concurrent diseases of that patient. Direct healing is healing that occurs directly between the fracture fragments without a cartilaginous stage and no observable callus. And this is fibrous bone that forms and then followed by remodeling and reconstruction of the Haversian system across the fracture. Please learn more about your direct and indirect healing in your surgery lectures. To see direct healing, that requires excellent anatomic reduction and alignment with very rigid fixation, and there should be very minimal, less than 1/3 of a millimeter gap. Radiographically, when a patient is undergoing direct healing, there will be general lack of callus, maybe some bit of endosteal thickening, and then gradual loss in opacity of the fragment ends with progressive loss of the fracture line and ultimately cortical continuity. This is an example of a patient that had direct healing of a radial fracture. So the immediate post-operative views show a rigid stabilization with plate and screws. The fracture of the radius is at this level, but it is barely visible. There's excellent anatomic alignment and really no gap. So this is a distal diaphyseal radial fracture. There's also an ulnar fracture, which is the fracture line that we're seeing off to the side here. On the recheck radiograph, there is lack of visibility of the radial fracture, but there is no callus with continuity of the cortices. There is some periosteal reaction over here, which is really associated with that ulnar fracture. So this is an example of direct healing. More often than not, we're going to see evidence of indirect healing, and indirect healing involves callus formation using both intramembranous and endochondral ossification. And there is a process that starts with a hematoma with some inflammation that turns into granulation tissue, followed by fibrous connective tissue, which is then replaced by fibrocartilage, and then there is endochondral ossification. And so that is the callus that we'll see on the radiograph. This occurs in fractures in which some movement is possible because of the lack of extreme rigid stabilization. Radiographically, there's kind of a process depending on when you take the radiographs that we'll see. So if we took radiographs within a week, we'd first see osseous resorption, and that's while we're having the hematoma and granulation and fibrous connective tissue. Then by about 2 to 3 weeks, we'll see that radiographically apparent periosteal and endosteal callus. That callus will bridge and start to remodel by about 4 to 5 weeks, and then there will be continued remodeling until ultimately we get continuity of the medullary cavity and the cortex, and typically that'll be visible by at least 12 weeks, if not sooner. This is an example of a calf that had transverse mid-diaphyseal radial and distal diaphyseal ulnar fractures. You can see that there is some cranial and lateral displacement. This patient was stabilized with external coaptation, so they used a cast. And on a 3-week recheck, there is an example of good periosteal and some endosteal callus. It's circumferential. We can still see the fracture line, but it's much less visible. So this is indirect healing with callus formation. Here's an example of a young dog that had a proximal diaphyseal kind of short oblique tibial fracture along with a fibular fracture. This was repaired with an interlocking nail that's not quite as stable as some plate and screw fixations. And so on our recheck, we can see that there's quite a bit of periosteal, which is the external callus here, and then endosteal, which is the internal callus that's actually leading to that medullary cavity being a little bit more narrowed. So a nice callus periosteal and endosteal circumferentially, and that fracture is healed. So it takes us into a discussion of how do we know if a fracture is healed. And so when we are looking at radiographs, a radiographically healed fracture will have complete bridging callus. And remember that callus is not only periosteal, but could be endosteal or both. And that we will have continuity of the cortex and no remaining fracture line. However, there are some fractures that heal by fibrous union, so there will always be a radiolucent line even when it's fractured. And specifically, this would be the distal phalanx of a horse, but there are some stress fractures in horses that might also have a fibrous union. The other thing that we need to keep in mind is that fractures are often clinically healed, even if we can still see a bit of the fracture line on the radiographs. So here's a postoperative radiograph of a radial fracture in this dog that was stabilized with a plate and screws and a cerclage wire, so a proximal to mid diaphyseal fracture here. Ulnar fracture as well. And when we look on the recheck, we can see that I have barely any visibility of the fracture line. I have complete continuity of the cortex, and there's a little bit of periosteal and endosteal callus. This was a little bit of callus, so it's not quite direct healing. When you look at the ulna, there's actually nice circumferential callus formation and really no visibility of the fracture. And so that is a radiographically healed radial and ulnar fracture in this patient. Here's an example of a horse that has one of those incomplete fractures of the third metacarpal bone. This patient had quite a bit of fissuring proximally, but it still doesn't extend out the cortices, but it is an intra-articular. And on the follow-up, which just had stall rest for it, there is very poor visibility of the fracture lines, but there's quite a bit of sclerosis around those fracture lines. And so that is our mainly endosteal callus formation. Here's an example of a horse that has an incomplete fracture of the tibia. We actually saw this example before. The fracture line is visible through the medial cortex here and then extends proximally but not through the lateral cortex. This washer was at the level of a wound, so this was a blunt trauma fracture. And here is several weeks after. I can still see the fracture line, so it's unclear if this is actually going to heal with bone or be fibrous union, but there's extensive endosteal callus formation and sclerosis around that fracture. This slide just gives us a table that gives some expected time of healing in the dog based upon the age of patient and whether or not we have indirect healing or direct healing. And I don't want you to memorize it, but what I want you to notice is that we may see radiographic healing for indirect healing with callus formation more quickly than we do see it with direct healing. And then also notice that the younger the patient, the more quickly we'll get radiographic healing of our patient's fracture. When we look at radiographic evaluation of our fracture stabilization, we should obtain radiographs immediately after external or internal stabilization, and that's so that we can evaluate how we did. And then for recheck radiographs, they are generally obtained at 4-week intervals until the fracture is healed, but the actual interval will depend upon patient factors, the type of fracture, the type of stabilization, and if we have any concern for complications. Here's a cranial caudal view of a patient that had a tibial plateau leveling osteotomy, and this is a radiograph that was obtained immediately postoperatively, and this is just an example of why you would want to have an immediate postoperative or post-stabilization set of radiographs, because it was identified that this screw is actually partially into that stifled joint, and so they went back, removed that screw, and replaced it more appropriately with a different screw. Here's an example of the same patient where initially the fracture of this middle phalanx was externally stabilized with a cast. And so we took lateral and DP views after that stabilization to make sure that the fracture stabilization was what we wanted. But then this patient went on to have an internal stabilization with arthrodesis of that proximal interphalangeal joint, because it was an intra-articular fracture, as well as some other intrafragmentary screw stabilization of the fracture. And so they obtained radiographs immediately postoperatively to ensure that the surgery accomplished what the goals were. Here's an example series of a dog that had a radial and an ulnar fracture. The radial fracture was stabilized with a plate and screws, and the ulnar fracture was stabilized with an intramedullary pin. So immediately post-operatively, we have our lateral and cranial caudal views. You can see the fractures there. At 4-week recheck, we see some callus formation and some both periosteal and endosteal. We still see the fracture line, and in fact, sometimes we might see a little bit larger fracture line from some of that resorption. We can see that there's kind of an irregular callus on the cranial caudal view, and then there's some soft tissue swelling. At 8-week recheck, we have some remodeling of that callus on both the radial and the ulnar fractures. The fracture line is even less visible, but still present. And then on this 12-week recheck, we can see that there has been additional remodeling. The callus is less exuberant, shall we say. We still see the fracture lines, but it seems that there is circumferential bridging callus, so we're looking for complete bridging callus when we assess for healing. And although we can faintly see the radiolucent line of the fracture in the radius and the ulna, with that complete circumferential callus formation and this patient doing well and the fractures feeling stable, they did not take any more radiographs and considered this healed. Here's another patient. These are the preoperative radiographs that show that there is a spiral fracture of the mid-diaphysis and distal diaphysis of the tibia, along with a proximal diaphyseal fibular fracture. And this was stabilized with a plate with many screws here. They have great anatomic alignment and reduction with really no gap at that fracture. I can barely see the fracture line on this view. And here at the first recheck, which in this case was taken at 6 weeks, so depending upon the patient and the fracture type and surgery, they may not do 4 weeks. I cannot any longer see that fracture line. I see continuity of the cortex and the medullary cavity. This proximal fibular fracture really hasn't healed, but that's not a weight-bearing fracture, so we probably won't have to worry about it. Here's an example of a young patient, very young patient, 3-month-old dog, that also had a spiral fracture of the mid to distal diaphysis of the tibia. And in this patient, it was determined to do external stabilization with a splint. And because it's a young patient and because it's not a rigid stabilization, they took recheck radiographs at a 2-week interval. We can still see the fracture. There's a little bit of caudal displacement at the fracture, but we can see that there is callus formation, both periosteal and endosteal, with that sclerosis. And then at a 1-month or 4-week recheck, we can actually see that that callus formation is completely bridging all of the sides of the fracture compared to the 2-week recheck. Although I still see the fracture line, this is doing well and is probably almost healed. If you would like to read more about this topic or see some additional examples, refer to the recommended reading.